Today I will talk about diabetic retinopathy. What's the diabetic retinopathy? Actually, the diabetes patients are very prone to get the retinopathy. The retinopathy is problem in the retina, and by that these patients can get the visual loss. Okay, but there are some specific risk factors. If these risk factors are present, it means there are high chances for the diabetes patients to get the diabetic retinopathy. What are these risk factors? Let's talk about them. The first one is duration. Duration means how many years it's been the diabetes patients has been diagnosed with the diabetes. Okay, the more the years, the higher the chances to get the diabetic retinopathy. This is a very important prognostic factor for the diabetic retinopathy. Okay, what's next one? The poor control. Poor control means if the patient is not controlling the blood glucose well, these patients are at high risk for the diabetic retinopathy. What's next? The next one is hypertension. Hypertension. So, of course, if the patient has a diabetes mellitus plus hypertension both, these patients are at high risk. Okay. One is pregnancy. The pregnancy, how these patients can have the gestational diabetes mellitus or the diabetes mellitus type 2 or 1, anything before the pregnancy. No? If they get the diabetes during the pregnancy or they had before, anything. In both cases, they are at high risk for the diabetic retinopathy. So let's re-revise it. The risk factors of the diabetic retinopathy are duration, worse control of the blood glucose, hypertension, and pregnancy. Okay, duration, poor control, hypertension, and pregnancy. Okay, now you can ask that should we screen these patients? Should we screen the diabetic patients for the retinopathy? Yes. When the patient comes to you and you get to know that the patient has type 2 diabetes, in that case you will check it. You'll check for the diabetic retinopathy immediately when the diagnosis is made, okay? Immediately. But if the patient has type 1 diabetes, in that case, you will check it after 5 years, okay? So, if it's type 2 diabetes, you will check it immediately, okay? If it's type 1 diabetes, you'll check it 5 years later. And after that, in both cases, twice in every year. Okay. In type 2 diabetes, immediately you will check. After that, once in every year. In type 1 diabetes, you will check it after 5 years. And after that, after 5 years, you will check on the 6th year or the 7th year, every year once only. What are the clinical features we can expect in the patients of diabetic retinopathy? The symptoms are related with the vision because it's retinopathy. And these symptoms are blurred vision, fluctuating vision, and loss of impaired color vision. Okay. Do you remember which are the cells responsible for the color vision? Are they rods or cones? They are cones, right? Okay. Or the next symptom is the floaters. Okay. Floaters in front of the eyes. Okay. The earliest manifestation of the diabetic retinopathy is microaneurysms. Microaneurysms are the small bubbles, okay, the small balloons which are originating from the blood vessels, okay. So they are earliest symptoms. So this is the earliest symptom, the microaneurysms. And one symptom is there which is very specific for the retinopathy, which is neovascularization. Whenever you check the eyes, we'll see some new blood vessels forming out there on the retina. And they're very important. These are neovascularization. Okay. Now speak with me to learn it, okay? Blurred vision, fluctuating vision, impaired color vision, floaters, microaneurysms, and neovascularization, okay? Blurred vision, fluctuating vision, impaired color vision, floaters, microaneurysm, and the neovascularization. What's the pathology? Just remember 2 words, okay? 2 words only. These are occlusion and leakage. Okay, occlusion and leakage. Why occlusion? Because the patients with the diabetes mellitus, they are more prone to thromboembolisms. Okay, so these thromboembolic patients, these diabetic patients with the thromboembolisms, they can have the occlusions, yes, of the blood vessels, right? And due to occlusion of the blood vessels in the retina, these patients will have hypoxic retinas. So they will have hypoxias, right? And due to hypoxia, they will have increased VEGF. What is VEGF? VEGF is a vascular endothelial growth factor. Okay, this is a protein which is promoting the growth of the new blood vessels. Okay, again, this is vascular endothelial growth factor. And as the name is telling, it's promoting the growth of the new blood vessels. So due to the VEGF, the neovascularization will occur. These two symptoms, okay, we are explaining with these two words, okay, the occlusion and the leakage. Due to occlusion, we are having the neovascularization. What about leakage? The leakage happens due to pericyte necrosis. Okay, if this is the blood vessel, let's say this is a blood vessel, so inside of that are endothelial cells. Okay, that will make the endothelial cells. Okay, and outer side we have the pericytes. It should be generally 1:1. It means the one pericyte. Okay, let me change the color. If it's one pericyte, in front of it, it should be one endothelium cell. Okay, 2, 3, 4, like that. Okay, 1:1. Okay, but what happens in the pericyte necrosis? That means the decreased number of the pericytes, right? Okay, if we have this much endothelial cells inside, and in the pericyte necrosis, we have just 1:4 ratio. It means just one pericyte is there in front of 4 endothelial cells. Okay, so it means the pericyte number is decreasing. If the pericyte would the number will decrease, it means that due to pressure, this thing will bulge out, right? So it means the ballooning of this blood vessel will occur, right? Due to balloon, so as I already told you, the small blood vessels, the small balloons in the blood vessels, they are called as microaneurysms. So these are microaneurysms, and due to microaneurysms, the leakage can occur. So this is the whole thing of diabetic retinopathy. This is a pathology. So you should remember just two words: this is occlusion and the leakage. Due to occlusion, we have neovascularization, the new blood formations, because hypoxia is there. Due to hypoxia, VEGF, the vascular endothelial growth factor, will appear. And due to that, we'll have the neovascularization, the new blood formation. Okay? But in the leakage, why the leakage occurs? Because of the pericyte necrosis. Okay? In the pericyte necrosis, the number of pericyte will decrease. Due to that, the ballooning will occur whenever there is an impression. Due to that, the balloon will form. The small balloons will form in the blood vessels. And these balloons are called as microaneurysms. And these microaneurysms can cause the leakage. Okay? There are two types of diabetic retinopathy. These are non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Okay? The NPDR and the PDR. Okay? In the NPDR, so just one word you will remember, sir, proliferative. Here we don't have proliferation, here we have the proliferation, and you can connect the proliferation word with the neovascularization, because proliferation means to increase and neovascularization also to increase the blood vessels, number of the blood vessels, yes, the formation of the new blood vessels. So it means the neovascularization is present in the proliferative diabetic retinopathy, and that's not present in the non-proliferative one. If the neovascularization is not there in the non-proliferative diabetic retinopathy, then what is there? These are four things you will remember for the, you have to remember for the NPDR. Okay, get about NPDR. The proliferation, the neovascularization is not there, but these four symptoms, these four things are there which you will remember. Okay, what are these? Let's talk about them one by one. So first photo we have is this one, in which you can see the dot and blot hemorrhages. These are hemorrhages, okay? As I told you, the second word in the pathology was leakage. And the leakage happened due to microaneurysms, right? And the microaneurysms can leak. This is the photo of the leakage. Okay? So hemorrhages you will see like this on the retina, and these are dot and blot hemorrhages. Okay? Okay, let me write here dot and blot. The specific names out there, you will have to remember it. Okay. The second one is, the second one we have is microaneurysm itself. Okay. Microaneurysms are present. As you can see, it's very, very small aneurysm is present there. The small bulge from the blood vessel, and that is a microaneurysm. And this is the earliest manifestation. Okay. This is the earliest manifestation you will see on the retina in the NPDR. What? Third thing. The third thing we have is exudate. Third and fourth, these are exudates. So see the difference between both exudates. These are, the first one we have is the soft exudate, which is also called as cotton wool exudate. These are the exudates you can see. Okay. Something is deposited here, right? Something is deposited, some debris is there, which is deposited there, and this is due to occlusion of the blood vessels. Okay, this is called as cotton wool exudates. And this one is your microaneurysm. Okay, the second exudate we have is hard exudate. The hard exudate you can see here, this is very specific and clearly visible. The hard exudates are due to leakage on the retina. Okay, due to leakage, we have lipid deposition on the retina, and that is your hard exudate. Yes, let's revise it again. So let me write here hard exudate again. The first one was dot and blot hemorrhage. Second is microaneurysm. Third is cotton wool, and fourth is hard exudate. Okay, what's the cause of hard exudate? Lipid deposition on the retina due to leakage. But the cotton wool appearance, the cotton wool exudates or soft exudates, these are due to the debris deposition due to occlusion. Yes, these four things are present in the NPDR. Okay, but what is the cause of vision loss? You know, in any kind of diabetic retinopathy, we have the vision loss, right? In the NPDR, we have different cause of that vision loss, and in the PDR, we have different cause of vision loss. In the NPDR, the main cause of vision loss is macular edema. Okay, will you remember it? Macular edema. Okay, this could be a very important MCQ question. Macular edema is the commonest cause for vision loss in the NPDR. Okay. Next was PDR. In the PDR, this is a PDR, proliferative. Now we have the proliferation. It means there is neovascularization. There are two types. If the neovascularization is present on the disc, this is called as neovascularization of disc. Okay, the first type. Second type is NVE. If the neovascularization is elsewhere from the disc. If it's on the disc, this is NVD. If it's elsewhere, this is neovascularization elsewhere, NVE. Okay, these two types are there of the PDR. Now, as I told you, there is a different cause of the vision loss in the PDR from the NPDR, right? In the NPDR, it was macular edema. And in the PDR, it is vitreous hemorrhage. What is it? Vitreous hemorrhage. The cause of vision loss in PDR is vitreous hemorrhage. Okay. Okay. Let's revise both of them again. First of all, in the NPDR, if it is proliferative, it means there is neovascularization. In the non-proliferative, it means there is no neovascularization. Other than neovascularization, what are the main symptoms, main signs in the non-proliferative diabetic retinopathy? These are these four. These are total root hemorrhage, macular edema, open wound appearance, soft exudates, and hard exudates. And in the PDR, we have two types. If the proliferation, the neovascularization is present on the disc, this is NED. If it's elsewhere, this is NEC. And the cause of vision loss on the NPDR was macular edema. In NPDR, it is macular edema. But in the PDR, this is vitreous hemorrhage. Okay. How do we treat the diabetic retinopathy? So as you know, macular edema is very important thing in the NPDR. So for that, we will use the intravitreal steroids. Okay. We can use a laser photocoagulation. And in the laser photocoagulation, we use the double frequency of ND-YAG laser. Do you remember it? This is ND-YAG laser. The name of laser is ND-YAG laser. Okay. Okay. And we use the anti-VEGF drugs. Some of the examples are there, which are bevacizumab, and we can use ranibizumab. Sorry, ranibizumab. Or ranibizumab. So these drugs can be used, okay? Okay, intravitreal steroids, laser photocoagulation with anti-YAG laser, anti-VEGF drugs, okay? And in the PDR, we can use a retinal photocoagulation. Retinal photocoagulation, what we are doing, this is very focal, okay? Wherever the problem is, we will just use this laser, this photocoagulation there only, where we use 60 to 80 degrees Celsius of temperature, and we just seal the blood vessels there, okay? But here, the recurrence is very common. For that, if the recurrence is there or we want the permanent treatment, for that we can use the pan-retinal coagulation. In the pan-retinal coagulation, we are coagulating the entire retina. We're just leaving the macula behind. And in that case, the hypoxia will be eliminated. Okay. So as we complete the topic here, so let's just take 1 minute to revise the whole video. Okay. What is diabetic retinopathy? This is the problem of the retina in the diabetes patients. Okay. What are the risk factors for that? These are duration, poor control of the blood glucose, pregnancy, and hypertension. Okay. Should we screen it? Yes, we should screen it. In the patients of diabetic 2 retinopathy, the diabetic 2 mellitus, diabetes mellitus, in that patients, we should check for the diabetic retinopathy immediately at the time of diagnosis. But in the patients of type 1 diabetes mellitus, we should check it 5 years later. Okay. And in both patients, we should check once in every year after that first checkup. In the clinical features, you will remember the floaters, okay, impaired color vision, fluctuating vision, blurred vision, right? Microaneurysms and neovascularization, these are very important topics, important symptoms of this. In pathology, you will remember occlusion and leakage. Occlusion, due to occlusion, we have neovascularization. And due to leakage, as I told you, the pericyte necrosis was there, and due to that ballooning out and microaneurysms were appearing, and the leakage was due to that. And in the classification, we had NPDR, non-proliferative, and PDR, proliferative diabetic retinopathy. In the NPDR, you will remember microaneurysms, hard exudates, soft exudates, and total growth hemorrhages. And the cause of vision loss on the NPDR was macular edema. In the PDR, we had two types, NVD, neovascularization of the disc, and NVE, neovascularization of the elsewhere. Okay, and the vision loss cause was vitreous hemorrhage in the PDR. Okay. And to treat it in the NPDR, we are using anti-VEGF drugs, laser photocoagulation, intravitreal steroids. In the PDR, we are using retinal photocoagulation and pan-retinal coagulation.